So I want to thank Ruby for the introduction. I would also like to thank the entire nursing education team for being amazing. I would love to thank Andrew as well as Irene Masick, who both absolutely agreed that this was a very important topic to cover and were essential and very helpful in having us present. So welcome everybody and thank you for coming. This Grand Rounds is called Healthcare Approach to Gun Violence Prevention. As any good Grand Rounds, we do have some objectives here. We would love for you to leave today's Grand Rounds gaining knowledge about gun violence through our data and statistics that we will share. We want you to understand your role as a healthcare provider in order to prevent gun violence. We're going to review some therapeutic communication techniques and strategies with everyone. We're going to gain some insight into Northwell's Gun Violence Prevention Center and our North Shore University Workplace Violence Committee. We're going to learn a little bit more about gun safety here at North Shore University Hospital, and we have two amazing guest speakers that are going to allow us to achieve these objectives. All right, let's begin. How does gun violence impact our communities? I think that everybody believes that they know a little bit about gun violence, right? We hear it on the news, we read it in the social media, but Loveland and I really wanted to share some data and statistics. In 2021, there were 48,830 gun-related deaths in the United States. Putting it into our health care perspective, there is approximately, on a 5-year average, 43 deaths due to breast cancer and 49 deaths due to pancreatic cancer. The big difference here is that there is relentless research for breast cancer and pancreatic cancer. There is screening that we empower and encourage our patients to go and complete. And there's also a lot of funding, right? Not so much for gun violence prevention, even though our numbers are pretty much the same. An average of 320 people are shot in the United States daily. 110 of them die and 210 survive. Once again, putting it into the healthcare perspective, and not to undermine any of these numbers, 32 people die from drunk driving daily, and 44 people die from overdoses daily. I can't help but to think of our SEWA patients down in the ER, right? When they come in, we make sure they're okay, their wounds are cared for, we sober them up, we give them a banana bag, we put them on a SEWA screen, and we make sure that once they're sober, they have the resources and options for rehab so that this doesn't happen again, so that they don't go out back into their car to drunk drive again and hurt themselves or others. Same thing goes for our overdose patients. When they come in, we stabilize them, make sure that they're okay. And then we have a group of people that come and talk to them, right? We have psych, we have our expert assessment, we have social workers, case managers. All are hands-on when it comes to these patients so that we make sure that they don't go home and hurt themselves. We have Narcan training, lots of Narcan training. Not so much for our gun violence patients or patients who come in with gun wounds. So there's a definite mental health component to this problem. And 2020 was a very tough year for all of us. So suicides accounted for more than 50% of gun-related deaths in 2020, exactly 54%, right? And I go back and I think about our suicidal ideation patients. When they're here, there's a constant observation order in place. We have checklists to make sure that the environment is okay. We do everything in our power so that they don't hurt themselves, right? So across all suicide attempts without a gun, 4% result in death. The efficiency of a firearm makes that figure go up to 90% success rate. So after all of our interventions here of keeping them safe and making sure that they don't harm themselves, somebody can go home, get a hold of an unsecured firearm and succeed in committing suicide. So having access to an unsecured firearm triples one's risk of death by suicide. And again, I think about adolescents, teenagers, maybe they're not the ones that own the gun, but if they have access to it, then their risk of suicide increases. Our geriatric population, the one that we care, we care for everyone, but we are so careful with them here, right? Make sure that they don't fall, they don't have skin breakdown, no cavities. Those aged 65 and older now have the highest rate of gun ownership in America. They also have high prevalence of depression and suicide in the United States. If you add cognitive decline to that, it increases the risk a lot more for hurting themselves or even others with a firearm. Couple more data slides, I promise. So here we have 19,000 children and teenagers are shot and killed or wounded annually in this country. 22 children and teens ages 1 through 17 are shot in the United States daily, out of which 5 die. 2 out of 5, believe it or not, are suicide, and 17 survive. This graph here from the Pew Research Center shows that there was a 50% increase between 2019 and 2021 in gun deaths in the United States with children. So firearm injuries are now the leading cause of death among children and adolescents, and we have surpassed car accidents, cancer, poisoning, and suffocation. So I think we've all been working towards decreasing healthcare disparities and making sure that everybody is getting equitable care, right? And that's something that we've been talking a lot, and it's all in all of our modules. However, Black youth are 17 times more likely to die by gun homicide than our white children. All right, so that was a lot of information, a lot of data, and if you've never heard it before, it could be overwhelming. So we'll take a moment, deep breath, because now we're going to talk solutions, right? So why is gun violence a public health problem? So when I started looking at all the public health problems, without going too deep into the history of public health, I was like, oh, we do that in nursing too. We do that as a healthcare institution too. We're trying to decline stroke and coronary artery disease. We just had a pandemic. We're trying to control infectious disease. We encourage everyone to get vaccinated. We try to make sure that everybody stops smoking or vaping. It's just what we do, right? Maternal and child health improvement, that's our priorities. So gun violence should be treated in the same manner with our public health perspective. Just a quick example of a problem that I thought was pretty interesting. Our motor vehicle accidents prior to 1960s were very fatal. People would just fly out through the windshield, through the window, because there were no seatbelts, right? So research was done, and they noted that seatbelts really decreased the possibility of death by 50%, and it decreased critical injuries by about 45%. And so now we see seatbelts everywhere, right? And of course, laws also helps. We get a fine if we don't wear it. But the bottom line is that we're saving lives by wearing a seatbelt. I had no idea seatbelts were so controversial in 1968. Very, very interesting fact.
So now, how does gun violence affect healthcare? As Gloria went over, how many people are shot daily? 320. 110 of them die, and 210 survive. Of those that survive, they are more likely to develop mental health conditions and substance use disorders. For example, children who are exposed to fatal shootings, their antidepressant use increases by 21% in the 2 years following the incident. Again, the ongoing physical and psychological pain does not involve the individual that was shot, but also the families and their communities. Whenever we talk about how much something is impacted, we talk about money. So now the gun violence affects a lot of financial on the healthcare side. Annually, a total of $1 billion is spent in initial medical costs, and about 75 million of that is just for ED visits only. On top of the initial medical costs, there are physical healthcare costs that includes inpatient or outpatient rehab, additional surgeries for the victim, long-term services, as well as medical equipment that patient needs when they go home. Behavioral healthcare are also in that money, where prescription drugs, substance use services, as well as crisis care. In 2020 alone, there are about $290 million or the cost for a fire-related death. The medical cost burdens the healthcare so much more than we know, and the impact is beyond the hospital doors. Gun violence affects our communities, and our communities are affected. Our individuals are affected by their communities. As we know, for example, we can have Grandma Lucy who has hypertension and diabetes, but they are too scared to go to their pharmacy to pick up their insulin or the hypertension medication. What happens? They end up in the hospital, readmitted or admitted for the first time because they've been non-compliant with their medications. They're either in DKA or they had just had a stroke. Stress of living in a community where there's gun violence also worsens their chronic conditions. As well, gun violence in Black communities, as we talk about the health equity and social determinants of health, the generational trauma and grief disproportionately affects the Black community. Research shows that the consequences are systemic, structurally disadvantaging those communities, leading to the lack of investments and loss of economic opportunities in those communities. So now we are all here to listen about data and learn about gun violence. The next question is, how can we be part of the solution? One of the things that me and Gloria actually ran into when we were doing our research on this topic was, how are we nurses, how are we doctors can be part of the solution? The New York State Nurses Association actually released this position on gun violence. As nurses, we can increase the education and understanding of the issue of gun violence. We develop the skills to prevent, advocate, and intervene when necessary. And we also do the reporting and contribute to the analysis of the data that's given to us. What are we? We're nurses, but we are also advocates, educators, as well as researchers. As the New York State Nurses Association said, registered professionals can play a critical role by educating the public and influencing policy about the responsibilities associated with gun ownership and potential detrimental effects in society when guns are used irresponsibly. The American Medical Association also supports release of the position on gun violence. They support common sense legislation, as for example, universal background checks, as well as waiting periods to purchase firearms. They also support legislation requiring box warnings on any firearm ammunitions produced in, sold in, or exported from the United States. They also believe that ghost guns should be subjected to the same regulations as traditional firearms. As doctors, we should also raise awareness on active shooters and life crisis drills that are developmentally appropriate. One more time, we are nurses, we are doctors, we are social workers, we are educators. Our role in gun violence prevention is to be educators, researchers, not only just healthcare providers.
So here, how can we be part of the solution? Again, another question, right? So as we mentioned, let's increase our knowledge and understanding of the problem, which you're all doing right now, and we're so grateful for that. Research. Nurses have been recently, especially in this building, empowered to do research, to perform your own research. So if this is a topic that you are interested in, please consider it as your future research. And one of the reasons why we don't have a lot of research, you know that research is essential for an evidence-based intervention, right? One of the reasons, I have to mention it, one of the reasons for there not being enough research is because there was something called the Dickey Amendment from 1997 to 2018, which stated none of the funds made available for injury prevention and control at the CDC may be used to advocate or promote gun control. So we're here now. It's over. The Dickey Amendment is out of place now. So if you guys are interested in doing research, please do so. Advocacy, which we spoke a lot about now. Therapeutic communication, we all remember that and do that on a daily basis, but we'll review it. And screenings. So with therapeutic communication, what do we get from that? We have people open up to us a lot more. There's a decreased chance of miscommunication. There's an increased sense of trust, and that allows for more shared information between you and your patient. Although we don't have gun safety or gun screening in this hospital yet, there is a violence abuse screen, and anybody who's done a nursing profile, this might look a little familiar to you. Let me just read those questions. Do you feel unsafe at home, work, or school? Do you feel like hurting yourself or others? Do you feel threatened by others? Have you experienced violence or a traumatic event? Raise your hand if you think these questions are a little uncomfortable sometimes to ask. Right? You know, and I've seen it, and maybe a couple of years back, maybe 10 years back when I started, I also kind of just ran through this real quick, maybe answered the question for the patient. You're good, right? You don't feel threatened, right? You're okay? Wrong, we shouldn't do that. So these are just some strategies. I'm not gonna bore you to death with them, but going back to, let's say, this question, do you feel unsafe at home, work, or school? Which is now more important than ever. Active listening, right? I know we're busy. Trust me, I worked in ED holding. I know what busy is. So, you know, we have profiles to do, medications to do. Our bed is not cold yet, but we have another patient on the way up. I get it. But those 15 minutes that you're taking to do a patient profile and ask these questions, let's listen to understand and not just to answer and fill in our questionnaire. Leads or open-ended questions. Like I said before, you feel safe at home, right? Everything okay? Right? You haven't experienced any violence, traumatic events. When you ask it in that manner, who's going to say like, wait, no, I'm unsafe? Picture your domestic violence patients. No one's going to be like, actually, I am not. Or but they might, but for the most part, they'll be like, yeah, no, I'm fine. Sharing observations. So if we see a patient is like shying away or, you know, looking at their partner or just their entire body language changes, maybe we can, you know, when you're alone with a patient, talk to them again. Like, you know, I saw that you kind of like turned your head away when I mentioned this. Is there anything you want to tell me? Anything you want to talk about? Paraphrasing, sometimes we got to change some words to make people feel comfortable. You know, when it comes to this screening, I always remember, I always ask them, like, okay, here comes a portion of your profile, which I don't have to, you know, we're all empathetic. But when we're in a rush and we have to get things done or we have critical patients, then maybe, you know, once you're done with your critical patient, come back to these questions because they're really, really important. And clarifying, sometimes patients will be like, well, yeah, kind of, sort of, they won't really answer the question. So again, if you have a moment to like, you know, I asked you this question. I didn't really get a clear answer, or maybe just repeat, like, I'm hearing that you're saying this. Am I understanding correctly? All right, so I actually really like this acronym. I'm not big on acronyms, but SOLAR. It just kind of reminds you of what we should be doing when we are speaking to patients so that it's a therapeutic manner. I know we don't sit, so don't worry. We'll do S for squarely, right? So that you don't want to make sure that we're face to face with our patients. We're not towering over them. We're not like a mile away from them. We're not giving them our back. We're face to face with them. O is our open posture. Body language experts often claim that crossed arms, legs can be a sign of hostility or conflict. L is for leaning forward, show that you're interested in what they have to say without invading their personal space. So please don't get too close. Eye contact when appropriate, right? Show interest, attentiveness towards the other person, but find your balance. Don't just stare at someone because then it'll be awkward. And I know we don't relax, so we'll do R for not rushing. Think of rush. We don't rush, right? So don't be in a rush to leave. If you have to come back, come back. Take care of what you got to do and then come back.
All right, so we were talking about screening earlier. Gloria talked about the SBIRT that we do for our CWEL patients. Right now, we don't have a gun assessment, a gun injury assessment screening, but there is a Northwell that our speaker will actually speak about it later. Basically, this is an assessment on firearm injury risk. There's using evidence-based preventative strategies. It pretty much gives the patient and the family the resources as well to prevent any violence and to see where they're at. If they feel like they're scared, we do refer them to someone or somewhere. Our speaker will speak more into this when she comes up here. The 5Ls of firearm safety screening is locked, loaded, little children and feeling low, and learned owner. Again, this is just to ask if the firearm is safely secured, if it's loaded, if there's any children in the house, if they're feeling depressed or low, or the owner has education on how to use the gun as well as how to safely store it. There are also hospital-based violence intervention programs that are available in the country where they're using advanced comprehensive models of care to address trauma, social determinants of health, and violence, and where they intersect. And we usually see the effects of this in our hospitals, in our ED, in our inpatient beds. 1 out of every 3 US households has access to firearms. One of the goals that Northwell has started as well with the Center of Gun Violence Prevention is to have this uncomfortable conversation, or to learn how to have this uncomfortable conversations with our friends and families. How we ask them about safe storage, how we ask about suicide, or if there's any resources for crisis support, as well as violence intervention programs, such as ERPO, which is Extreme Risk Protection Orders, is another topic that they do address if the patient or the family has one of these available, one of these on them. Again, I don't know if you've seen the commercials where I think it's one of the commercials where
The tiger one.
Oh, the tiger. Was it the tiger one? I don't know if you've seen the commercial about the tiger one that was from Northwell, where they asked, is there a tiger in the house? Which is basically the tiger is the gun. Is the tiger safely secured? It's just one of the ways to kind of break that ice, to make sure that we are safe, our children are safe, even when they're not in our care. And I think that's one of the reasons that me and Gloria actually really researched this topic, is how it affects. We are both moms. We are not just nurses, not just educators, but we are both moms, and we worry about where kids go when they are not on our site. So moving forward, I'm going to invite our next speaker, Emma Cornell. She's the Clinical Research Program Manager for the Center of Gun Violence Prevention at Northwell Health. She holds an MPH degree from Columbia's Mailman School of Public Health, where she pursued a specialized course of study in injury and violence prevention. Her work at the center aims to help further the evidence base for firearm injury prevention strategies at all levels of the health system. Please welcome Emma.
Okay, sorry about that, folks. So I'm Emma Cornell. I work at the Center for Gun Violence Prevention. It's really lovely to be here with you all today. I think that nursing and nursing leadership has been at the forefront of a lot of the work that we've been doing sort of to reduce firearm injury risk. And so I also just want to say thank you to all of you for all of the work that you do. Even if you're not aware of it, you have been helping our patients and have been helping with this cause in one way or another. So I just want to say thank you. So to begin with, I think sometimes when we talk about firearm violence, it's a little abstract. And so sometimes in certain audiences, I do think it's helpful to kind of have a visual of the effect. And with this audience, I don't actually need to provide you with a visual because I'm sure many of you know what this looks like. But my boss is the pediatric trauma surgeon. And so these next 2 slides are actually patients of his who he treated for gunshot wounds. This is a little baby who was shot and paralyzed. And this next photo is a little girl who was studying at her kitchen table and was shot in the neck in a drive-by shooting. And in both of these cases, the 2 little ones were both paralyzed. They're both alive and they're doing okay, all things considered. But I think when we talk about these statistics, it's important to remember that there's a face, there's a family, there's loved ones who are dealing with the sort of impact of gun violence every single day. And for many, the sort of intense disability that comes with firearm violence is inescapable. It requires folks to move into different homes that are perhaps one level where they don't need to climb upstairs. It may require moves to different neighborhoods because a family may feel unsafe. So there's really a ripple effect. And I think it's really important to just kind of remember that when we're talking about these kind of large scale data sets and these big statistics. So like the fabulous presenters had mentioned before, guns are now the leading cause of death for kids. I'm showing this graph because I do think it's helpful to look at the other lines, the other causes of death. What's really interesting is if you look at that top line, which is the motor vehicle crash, you can see that there's a really steady decline. And for years, motor vehicle crashes were the leading cause of death for kids. But as they mentioned before, what happened is we invested in seatbelt laws, we invested in backup cams, there were moms who got really mad and started Mothers Against Drunk Driving and lobbied and got support from across the country to change laws and to make things safer for our kids. And there are moms who are doing that for gun violence prevention too. So I'm not gonna, the Moms Demand Action has been a force to be reckoned with in this area, but we have not had that same level of sort of commitment across the board when it comes to what is now the leading cause of death for kids. So I also, these are from, I think, 2 days ago. These are just in 2023, some statistics. I'm not going to read them to you, but I think, you know, we're what, 4 or 5 months into 2023, and there have already been over 13,000 people who've been killed by guns in America and more than 10,000 who have been injured. And if, you know, if this were anything else, that wouldn't be acceptable and we would have been doing something about it by now. But because there's this sort of politicization of, again, the leading cause of death for kids, there's this unwillingness among many to engage with it as a public health issue. So the remainder of my talk, I'm going to kind of talk about ways that we can engage with it as a public health issue in a nonpartisan way to sort of make a difference for our patients and their families. You know, I also just think it's important, this was mentioned before, but when we talk a lot about health equity and health disparities, you cannot ignore that this disproportionately impacts communities of color and particularly Black men in America. So at the Center for Gun Violence Prevention, our goal is really to take like a public health approach to this issue. And so, you know, one of the things that came out of the pandemic is I think people have a slightly better understanding of public health. I say that with a grain of salt because we also saw that many folks seemed to have no understanding of public health. But one of the things that we've tried to do is to make an analogy to COVID, right? So when we talk about steps to flattening the curve, so mask wearing, social distancing, things like that, we can also do that with firearm violence. And so the main goal of the Center for Gun Violence Prevention is really to kind of take those public health steps to reduce the incidence and prevalence of firearm violence in America by taking a healthcare approach in the same way that we've taken steps to reduce infections and to, you know, reduce coronary artery disease. Whoopsie daisies. So, you know, these are just some examples of successful public health campaigns. Again, I know they were mentioned a little bit before, but again, I just think it's really helpful to contextualize what we're trying to do in the firearm injury prevention space with previous sort of successful public health campaigns. And not all of them have been easy, right? I think that's really an important thing to recognize. And we are, as Gloria mentioned, in kind of the infancy of this work because there was a basically congressional ban on research that only recently expired. So 2018 was when the ban was lifted. And so compared to things like workplace safety or motor vehicle accidents, where we have 20 plus years of evidence-based public health research, the same is not true for firearm injury prevention because there was no funding for so long. So we really are in the infancy of this work. So the center takes a couple of different sort of approaches. One of the biggest things, and I'm going to talk about this in a second more, is we really try to destigmatize and depolarize the conversation around gun violence. We draw a lot of analogies to some of the really successful work that has been done across Northwell with regards to substance use. Because one of the things that Northwell has done really well is take a very sort of harm reduction informed public health approach to substance use, where everybody is asked about whether or not they have a concern for substance use. If they screen positive for substance use, then they're care navigators who can come and see the patient, right? There's mechanisms in place to help support these patients. And that's because there's been constant education, there's been conversations, things are not sort of, we don't shy away from having these conversations, even if they're uncomfortable, because what that does is it creates a space for our patients to be honest with us and to identify that they are having struggles, and then we can provide them with resources. The other sort of areas that sort of are the pillars of our center are obviously charting a public health approach. The Implementation of evidence-based strategies is a huge one for us. I'm going to talk about our universal screening program in a second, kind of tell you what that entails. And then another big part of this is sort of working in partnership with communities, particularly those who have been impacted by gun violence. So too often in academic medicine, we tend to kind of take a very sort of us versus them approach where we say, we know what's best for you. Here, have a packet of resources. And instead, what we're really trying to do is to work in partnership with communities. So bring them to the table, say, what do you need? What resources are helpful to you? And then using that information to kind of help provide resource packets, to help provide care, whatever we can. So we have a couple of different arms at the Center for Gun Violence Prevention. So as I was just mentioning, we have a community outreach arm. So we work with schools, we work with community violence intervention groups, we work with law enforcement to make sure that they have the tools that they need to be successful, to talk about things like school safety, to talk about things like officer suicide. We have a research arm, which is what I lead. We have a policy and advocacy arm, and we have a clinical integration and a medical education arm. And I'm going to talk about both of those in a minute. This is just a brief slide of some of the things that we've accomplished, and it's by no means complete, but one of the things, and I'm going to talk about this in a second, that we've really tried to do is also bring together other health systems across the country. So there are really good health systems doing really good work on this issue, but oftentimes it's very siloed, right? So there's really good work being done by a team of social workers in Chicago. But the team of doctors who just started a program in their trauma unit don't know about the work that's being done by the social workers in Chicago. And so because there's no communication that's happening, everything's very siloed. And instead, what we're really trying to do is bring all these people who are doing good work together into one space and share best practices. So we have a learning collaborative for hospitals and health systems that's brought together over 600 healthcare providers, health systems to do just what I said, which is talk about best practices, to share ideas. We just finished our phase 1, which was really just about sharing sort of programs that are going on in different hospitals and different healthcare settings. We're about to start phase 2, which is really focused on implementation and action. So how can we do this? Because one of the things that we get very often when we talk to folks across the US is, okay, this is great. I hear you that there's evidence behind this, but how can we actually do it? And so this phase is really focused on sort of giving people the tools that they need to start a program in their own space. And I'll have the link if anybody wants to join. It's really informative. I highly recommend it. So I'm going to talk a little bit about our research now. So we are funded by the NIH, and we have a implementation focused grant. The goal is to screen for firearm injury risk and access to firearms. And the name of our project is called FIMP, or Firearm Injury and Mortality Prevention. Basically what we do is we screen everybody who comes into 3 different emergency departments for firearm access and violence risk, regardless of your presentation. So if you come in for toe pain, you're going to get these questions. If you come in for a headache, you're going to get these questions. If you come in with a gunshot wound, provided that you are awake and coherent and able to answer the questions and they've stabilized all sort of acute life threats, those questions are asked. And then depending on the answers to these questions, if you screen positive, you get a certain type of intervention or resource. So I'll go through basically what happens. And sorry, the screen's a little funny, but essentially when a patient comes into the emergency room, a nurse in triage asks them, for our children, asks 2 questions. One is, do you have access to a firearm within or outside your home? And the second is, in the past 6 months, has anybody pulled a weapon on you? If the patient screens positive for those, it's documented on the tracking board. It's integrated into our EHR, so there's a FIMP note. So our providers are prompted to ask these questions. If the patient screens positive, what ends up happening is it will flag for social work to come and see the patient. We offer gun locks for patients who screen positive for firearm access, meaning that they have access to a gun within or outside of their home. And if they screen positive for violence risk, we connect them with local community violence intervention groups who can help provide things like behavioral health support, who can facilitate things like economic opportunities, who can help with applying for food stamps, whatever patients need, because we know that so many of those things are sort of underlying root causes of violence. So these are just the questions. And really the goal of these this whole sort of asking idea is we want to increase safety behaviors and we want to decrease firearm injury risk in a way that is helpful for the patient. So for some patients, they say, listen, I have a gun, I need it for protection. It's no good to me that you're saying you need to lock it unloaded. So a harm reduction approach to that is, okay, well, can we do something that's intermediary that can still increase safety a little bit, but will meet you where you are so that you feel comfortable? We're not asking you to do something that's completely uncomfortable for you, but you're also taking a step towards safety. So we use tools including motivational interviewing to sort of understand what the patient's goals are, and then we try to meet them with resources that they need. So again, these are just some of the things that we provide for firearm access if you screen positive, and then for violence risk. One of the things that has happened as a result of this universal screening is we've seen an incredible sort of embrace by the healthcare team members. So these are some photos from Wear Orange Day, which is coming up June 2nd this year. It's Gun Violence Awareness Day. And then also our team members sort of, without us prompting, instituted Firearm Safety Fridays, where they have these orange t-shirts and every Friday they wear them. And it's really cool. I actually went to the ED, on a Friday, didn't realize it was Friday, and I walked into a sea of orange. And to just see the sort of embrace by all these different healthcare team members who are saying this is an issue that affects our patients, this is something that we want to normalize, we're all wearing these orange t-shirts in solidarity, was really, really cool. So I'm just going to quickly go through a couple of additional clinical interventions. As was mentioned previously, we know that suicide accounts for the greatest sort of driver of firearm deaths in the United States. Oftentimes people talk and their biggest concern is mass shootings, and while those are obviously traumatizing and impactful, they actually only account for about 2% of gun violence in the US. So we know that there's an increase in guns that are owned in the US, right? Especially during the pandemic. There were 4.3 million new guns purchased just during 2020 alone. So that, in addition to the increases in suicidality that we've seen, create a really risky environment for some people. We also know that particularly with children, 43% of children who have a history of self-harm have access to a firearm in the home. And that statistic Gloria mentioned before, we know that when somebody uses a gun, 90% of those attempts are fatal compared to other means. What's important for us is the understanding that about 83% of patients who died by suicide did have some sort of encounter with a healthcare provider in the year prior to their death. So that tells us that there is an opportunity to intervene, to have a conversation, and to address some of these issues that we're seeing. So one thing I just want to draw everyone's attention to is lethal means counseling. For those of you who work in behavioral health, you're probably already familiar with this. Essentially what it is it's an evidence-based educational intervention. It doesn't take much time at all, but really what it tries to do is to work with the patient, the caregivers, the family members, to reduce access to lethal means during a period of vulnerability or crisis. So in the same way that we installed netting over bridges, in the same way that there was a scent added to carbon monoxide so that could be detected, that's lethal means restriction, right? We're reducing the risk of an existing lethal item. And one of the things that's really important with this is we know that most suicide attempts are impulsive. The impulse lasts only about 1 to 2 minutes. And so if you can reduce the time, or you can increase the time that it takes for somebody to access a weapon, and you can reduce that risk of them dying by suicide. This is just a schematic that kind of shows how lethal means counseling works. But one of the things that I want to draw everyone's attention to is that it's associated with a 75% reduction in suicide risk. There are not many things that we do in the clinical world that has that large of a percentage of success. But one of the problems is it's not routinely done because it's typically not taught, both in medical education and public health schools, for nursing education. There's an online class that you can do. I encourage everyone to do it. It's called the CALM, Counseling on Access to Lethal Means Training. It's a really wonderful publicly available course. And as I said before, it's not typically incorporated into formal training, despite it being a relatively low yield and despite it being something that many providers do already. I just want to kind of end by saying, some of the areas that we're really focusing on are making sure that universally healthcare providers across the spectrum, whether you're social work, nursing, NP, PA, are getting this education about the impact of firearm injury and sort of what they can do, because I think so often what happens is people feel really powerless and feel like there's nothing I can do. And if there's one thing you can take away from today, it's that that's just not true. In looking at kids specifically, only about 22% of pediatric trainees report having any kind of education about firearms, which is wild when you think about the sort of anticipatory guidance that any pediatric provider gives, whether it's helmets, seatbelts, things like that. And then, the area of implementation is another area that obviously we want to expand. So thinking about how we can use these firearm screenings as a preventative strategy, right? We don't want to be screening our patients when they come in with a bullet wound. We want to be screening them before so that we can reduce the risk of them coming in with a bullet wound in the first place. And then the biggest thing is, as I said before, is normalizing the conversation. So making this a public health issue, not a partisan issue, having a conversation with our patients is one of the best things that we can do. These are just some resources. I'm happy to take questions at the end, but thank you so much, everyone, for your time.
Our very own Director of Security, John Ferrigno, who's going to talk to us about safety here at Northford University Hospital.
Can you advance the slides so I can go by? Okay, thanks. Oh, that's how you do it. Hi, everyone. Thanks for having me. The main thing I'm going to focus on is answering some of the questions that come up in the hospital all the time to our office. And I just want to make sure everybody's clear on some things. First of all, employees of the hospital, no employee of the hospital, there's an exception, is allowed to carry a firearm into the hospital. If you're a legal licensed gun owner that has a carry permit, you're not allowed to carry a gun into the hospital. With that being said, the exception is security. In 2017, if those of you that were here, you remember we did an active shooter drill up on 8 Tower, where Nassau County ran a drill with their uniformed police officers, and we used our staff as actives throughout the hospital. So everyone got a real life experience of what it would feel like. The adrenaline does pump in situations, even though it's a training session. One of the questions that John Sendak received, and he was just stating this again recently, was that many of our employees said, if we had an active shooter situation, what do we do in the time that it takes the police to arrive to neutralize the threat? And the answer to that is working with corporate security. They allow former law enforcement that meet corporate criteria to carry firearms at work. We were the first ones to do it in March of 2018. We were the pilot program that was going to be the barometer for the whole organization. I'm happy to say we didn't get one phone call of negativity after this went live. It was something that staff wanted to make them feel secure, and it's something that they implemented. The criteria on corporate security is extremely strict. We added something to it that even though you were former law enforcement, I'll use myself as an example. When I retired, I hadn't shot my firearm in 5 years. I'm not a big gun carrying person outside of work before I came and worked here. It was really good to go through the course that we go through on a yearly basis. You have to go through a tactical course out at the range. It's an 8-hour shooting day, and you have to be proficient enough through the eyes of the Nassau County instructor, who was a former Nassau County police officer, police department firearm instructor. I can tell everyone here that everyone that's on my staff that carries a firearm has gone through this training and meets all the criteria of corporate security, and they have to be vetted by me. It's on my shoulders of who carries a firearm and who doesn't. I will tell you there are former law enforcement officers that have worked for me in the past that I did not allow to carry a firearm. So it's not everyone, it's the people that qualify. And one of the main things that they sign on for is, God forbid we have an incident at the hospital, we're going to neutralize the threat. While everybody else is leaving, we're going to go neutralize the threat. We've been training with Nassau County Bureau of Special Operations. For those of you that don't know what that is, that's like New York City's emergency service. We just did a drill with them, with our armed security staff and our unarmed security staff about a month ago in the building that had the boiler explosion that's closed. We're going to be doing that more and more. Actually, I was supposed to get more dates from them this past Monday. I haven't heard back from them yet. They're going to give us more dates, and we're going to try and do another live scale drill like we did up on 8 Tower. But just so everyone's aware, that's why they're carrying firearms. You'll see people in uniform with holsters, and there's people like myself on my team that are not in uniform that also carry firearms as well. But everyone's vetted under the same standards. Okay, with that being said, I've had questions raised, uniformed police officers that come into the hospital, do they have to carry their firearm? Yes, they do. Carrying a firearm as a uniformed police officer is part of your uniform. You're required to carry your firearm. What I tell everyone is I'd rather have a police officer here with a firearm than somebody that doesn't legally have the right to carry a firearm be in the hospital. I consider them an asset to me and to my team. If something happens, we're going to work together to neutralize that threat. Plainclothes officers that come into the hospital, they don't have to display their firearm. That's why they're plainclothes officers. But when they're in an environment that you come into and you're not working in that plainclothes capacity, even when you are out on the street, you are supposed to identify yourself as a police officer by your shield. Usually what you should do, and I'm not saying they do it all the time, I'm not saying everyone's right, I'm telling you what they should do. Usually if you carry your firearm, the side that you carry your firearm on, you would put your shield on your belt on the side of your firearm to let people know if they observe your firearm and they see your shield, it puts people a little bit at ease. Other police officers will carry their shields around their neck. You've seen them on lanyards like we have with our badges. They'll carry their shields there. You'll see police officers in suits. A lot of them carry it in their lapel pocket. Off-duty police officers. I personally never want anyone to know that I have a firearm on me. It's a tactical advantage to me. I know a lot of other former police officers and police officers feel the same way. I'd rather be able to surprise the person than the person surprise me. That's just my own personal thing, but I know a lot of other people feel that way too. I tell anybody in the hospital, if you see anybody with a firearm, call security. We're going to send somebody down there to check them out. A lot of times, I would say 99.9% of the times, the people that we come in contact with, all law enforcement, didn't realize their firearm was showing. When we bring it to their attention, bring it how it's upsetting people and it's making them a little bit uncomfortable. A lot of them will put their coats on. A lot of times that happens up in labor and delivery. Dads will take their coats off, not even realizing that they have their firearm on, and they get people uncomfortable. And it does happen. I'm not going to say it doesn't. The one other thing I just want to say about them is with Governor Hochul's new ruling in New York State, where they can't. An off-duty police officer or a retired law enforcement officer is exempt from this ruling, meaning that they can go into sensitive areas with their firearm. So being an off-duty police officer coming to the hospital, he is allowed to have his firearm with him. No licensed firearm owner is allowed to come into the hospital unless you're former law enforcement or current law enforcement. Just want to make that clear. We are going to be getting a weapons detection system down in the ED. That's the first place that it's going in. I just got confirmation. We're getting the awning up in 3 to 4 weeks, so it should be in right after that. That's the first place that it's going to be implemented, and it's going to continue from there. And these rules will be enforced with anyone coming in. We have had instances where I don't think this is the smartest move. If you know you're coming in for a procedure and you're a police officer or a law enforcement officer and you know you may be under anesthesia or may be incapable of bringing your firearm, why would you bring your firearm to the procedure? That has happened. We've had it in the ED. We've had it up in some of the units. If that does happen, please call security. We have lockboxes specifically for that purpose that are used in the police precincts. It's exactly like the precincts. They lock the firearm in the gun locker. We give them the key. Okay, if they're not able to hold the key, we'll hold the key for them. All right. And the last thing, just want to make sure I get this one. We had a police officer come down into the ED not too long ago on duty. They had to do something on him. I don't know what they had to do, but he had to give his firearm up. He would not give it to anyone because he was on duty. That's absolutely correct. Usually when a police officer comes to the hospital, there'll always be one police personnel member with him. The purpose of that is to safeguard his equipment or her equipment. He was definitely right saying, I'm not giving up my firearm until somebody from my precinct comes. I think it was the commanding officer of the precinct that came and took his firearm. If the situation where that's not available and nobody from his precinct's coming, we do the same thing. We'd offer him the ability to lock his firearm in a gun safe that we have. The security desk, we have him down in the ED, we have him up in my office. We'll help anybody secure their firearm to make it safe. Next one. Okay. Now that I said that, I just want to do a little bit on the workplace violence. We just went through the Joint Commission. They did a great job, and the team, the Workplace Violence Committee. Just so you know, all types of workplace violence are employee on employee. We have a few of them. Visitors on employee, family members getting upset, whether it be about care, whether it be fighting with their loved ones in the room. We have that. Big one that we have is patient on employee. I would say that's probably the majority of them. Whatever the reason being, it's deemed workplace violence by the definition of workplace violence. There's a lot of that. The active shooter. Active shooter training, like I said, we've been doing it with Bureau of Special Operations. God forbid that never happens here. We don't want it anywhere. Everything that we're putting into effect, trying to harden the hospital, it's a deterrent. Everything that's happening here is the deterrent. What we're hoping for is go somewhere else. That's the totally honest, best way I can say it. Go someplace else. If we have to deal with it, we will. The training's going on, and I just want to make one thing known to people. Up to the 3rd floor, I think we are right now, we're making safe rooms. Some of you have probably seen them already. They're rooms, it's just another tool to deal with this. They're rooms that have bolts on the other side of the door. You close the door, the bolt drops into a pre-seated hole in the floor that we have set up with engineering. It secures the room. If somebody has the key or somebody has the combination, you still can't enter the room. The bolt is what locks you in the room. It's a steel bolt. You're not opening the door. People say, oh, there's windows. There's window in the door. The walls aren't protecting you as well. But these people, what they know is that they have a limited amount of time to do the most amount of damage that they can. If they go to a locked door, the statistics show they're leaving that door and going to the next one. I'm not saying it's fail-safe. It's just another tool to use if you can't run away from the situation. I never really took that seriously until I heard some of our employees that we put these safe rooms in say, I had nowhere to go. Either they had a disability or some other ailment where they wouldn't be able to run away from the situation. We're giving them a means to secure in place to protect themselves and others in the office or in the environment that they're in. I just want to bring up some of the training that's available to everyone. And I wrote them down because those of you that know Billy DeLurth in my office, Billy runs most of the training. Some of the training's online, some of the training is in person. One of the ones that corporate security put out was North Shore Health, Safe Place, and Enrichment. It's a 3-part. It's stop the bleed, to stop hemorrhaging, any type of heavy bleeding, de-escalation training, and active shooter training. The de-escalation training, my staff has taken it all. They've taken all these. De-escalation training works. Sometimes the buzzwords that you're saying to people are the things that are triggering them, and there's words that they tell you to utilize instead of using other words that don't have that same effect on them. It's actually real good. You could do it online at your leisure. The other one, I haven't taken this one. Workforce Safety put out a good one. It's verbal de-escalation. It's about 40 minutes. Billy took this one and told me just this morning that one is a really, really good course to take, just to teach people or reinforce how to speak to people. CAB training, calming aggressive behavior. We used to do classes on this. We weren't getting the turnout for the classes. So I couldn't bring that instructor in every week and have no people or 1 or 2 people show up to the class. It wasn't effective for us to be doing that. We've offered this type of training to actual floors. I think we did them up on Fort Cohen. I'm pretty sure we did it up there, right, Danielle? Where we set it up with Danielle. We don't have to do it all in one day because I understand your staff isn't available all at once. But we'll do training courses up on your floor, which what I think we did with yours. We did it in sections. We could do your whole floor to get everybody on the same page. The other one is the calming crisis management training. It's crisis management techniques, CMT training, which every one of my security officers has to take, and they have to refresh on it yearly. That's a hands-on course. If people are interested in that, I would say contact the office. We'll try and see what works for you with your schedule and your staffing. We'll try and make it work for you to get as much training out to everyone as we can. All right, our whole thing is to make everyone feel a little bit more comfortable and a little bit more confident. This active shooter training that they have online, it's not just for here, but you take your children to the mall, you're in a restaurant, things they teach you is look for the exits in every room. Know where your exits are on your floors. Know an alternative way of getting out if that's the way that's being blocked. It's just things that you can use in your everyday life to protect you and your family. I'm always available. If anybody has any questions or concerns or suggestions, please let me know. Can't say we can use them all, but I'll be more than happy to entertain them. All right, thank you for your time. Anybody have any questions? I'll be more than happy to answer. One more thing. Okay, each safe room that I've talked about, the only reason I mention it to you because I know some people have it here. We've done all the other floors. We've worked with engineering and we've identified rooms on all the other floors. There has to be some testing done that engineering is having conducted right now to drill into the floors to put the holders in for these bolts. Each room has an instruction sheet right next to the bolt. It's attached to the wall with a fire extinguisher. You know the fire extinguisher, you pull the pin out, there's a little like zip tie there that's real easy to break. That's how each of these bolts are secured to the wall on an eye hook with the instructions right next to it. Real simple, pull the hook off the wall, drop it in the hole, the room's secure. We tell people, and you'll see right on there, turn the lights out, turn your phones off, be quiet, stay away from any windows or openings that people can look in. We are planning on doing a small video of it once most of the rooms are done, because right now, if we put that video out, more of the staff than not that don't have this room yet. But we are putting them in. I have all the bolts in my office. As soon as they're done, we're going to drop them in. We educate the nurse managers on the floor, and we ask them to give it to the staff. Okay? All right. Thanks, everyone.